Chapter 8 audio lecture on the joints. And so far, we've looked at all the different categories. We've looked at a lot of different structures and the terminology of our articulations or our joints. Part 3 of this one is more like the labeling part, and we just want to look at some specific joints in the body, and specifically like the knee, the shoulder, and the hip. Okay, so the knee joint is the first one we're going to look at. So it's going to be the largest, most complex joint in the body. It's a single joint cavity, okay, but one of the things that people always kind of forget about is that there's actually two joints in there, okay? So there's a joint between the patella and the kneecap, or the patella or the kneecap and the femur, and then there's going to be the one that we think about most of the time, which is the femur and the tibia. So again, the femur is going to come down, sit right on top of the tibia, and we're going to create this motion, which is going to end up being our knee joint, okay? So just remember that because that's a good also multiple choice question. But it's going to be enclosed by a capsule laterally and posteriorly, so on the sides and in the back. It's going to be covered by three broad ligaments anteriorly or in the front. We're going to have this patellar ligament, which is the one that most people think about centrally. And then we're going to have these medial and lateral patella or kneecap retinacula. Okay, so the patellar ligaments are going to be a continuation of the quadricep tendon. So all your quadricep muscles are going to come down, form this big huge tendon that's going to attach on that tibial tuberosity, and then the knee is going to contain two main types of joint ligaments that are going to help to stabilize and strengthen them. And some of these are the ones that we hear about when we talk about like football or baseball or different little soccer kind of injuries. You know, the extracapsular or the intracapsular ones are the ones that we can kind of sprain and injure and kind of tear. So let's take a look at those real quick. So here's our first picture, and we want to find the patella. This lets us know that we're looking at the front part of the knee, right? Because I can see the patella, and then I see the fibula over here, and that lets me know that this is the lateral side, okay? So again, first thing you always want to do is just orientate yourself. Am I looking at the front? Am I looking at the back? Where's the lateral side? Where's the medial side? Because again, this is going to help me. Knowing that this fibula is on the lateral side is going to help me name all these ligaments properly, and it's also going to help me to figure out if I asked you a question like, okay, what knee is this? You want to sort of be able to orientate yourself and sort of figure out that, hey, this is going to be my right knee because the kneecap's in the front, the fibula is on that lateral side, and then you want to sort of think about your own knee and figure out, okay, if I placed all these things in the proper spot on my knee, which one would I be looking at? Okay, but here is my patellar tendon. And again, we have this patella or the sesamoid bone inside the tendon, and then I get these little, retinacula. Okay, so this is my medial patellar retinaculum. This is going to be my lateral patellar retinaculum, and then I can start to see that I get these little collateral ligaments on the sides here. But we'll come back and talk about those in a second too. Okay, so these are my extracapsular ligaments. Okay, so I have a fibular lateral or lateral collateral ligament. So again, you'll hear these kind of termed a little bit differently. It used to be really common to call them the fibular collateral ligaments, but we've sort of made it a little bit easier, and a lot of people are just going to call it the lateral collateral ligament. So the fibular one makes sense because we know the fibula is on the lateral side, but I think it's always easier just to think about it as this lateral collateral ligament. Okay, and it's lateral, and then this is my femur to my fibula. Okay, so the ligament is going to run from the femur to the fibula, and again, it's going to be that ligament that's on that lateral side. We're also going to have a tibial collateral or a medial collateral ligament. And again, this one's going to be on the medial side, but it's also going to be going again from the femur to the tibia. We're going to get a couple other ligaments that are maybe, not so important, but you'll see them kind of pop up on some pictures here. You get an oblique popliteal ligament. This is going to be in the backside or the posterior part. And we're also going to get this arcuate popliteal ligament. And again, it's going to be posterior. And if you think about the posterior part of your knee, or you take your fingers and you kind of put it back there, you can see that it's kind of just this open pocket. Okay, so most of that stability is going to come from everything in the front and on the sides. So we come back to this picture, and all we've added, okay, we want to again find that quadriceps tendon. We want to find our retinaculum, and then we just want to add in fibular collateral or lateral collateral ligament, and then we want to add in the tibial collateral or the medial collateral. And then we just want to remember these are going to be the extracollateral or the extracapsular ligaments, okay, because they're going to be outside the capsule, okay, and then the intracapsular ones are going to be the ones that are going to kind of be on the inside. Okay, so here are those popliteal ones. Again, I'm not going to ask you the popliteal ones on your test, but make sure you know, obviously, quadriceps tendon, medial, lateral, collaterals. Okay, and then we'll look at the intracapsular ones. So these are my intracapsular ligaments. These are the ones more commonly called my cruciate ligaments, and they're going to cross each other, and they're going to form this little X, which is how they get their name. Their main job, and again, this is a good multiple choice question, is that they're preventing this anterior or posterior displacement, and we're talking about the femur and the tibia. Okay, so it's preventing sliding of the femur and the tibia sort of on top of each other. Okay, so a very good, important thing to remember is kind of what sort of motion are these preventing, and you always want to some people talk about it with the tibia moving, some people talk about with the femur moving. Either one is perfectly fine. You just have to remember, okay, which bone is moving anteriorly and which bone is moving posteriorly. Okay, and then for me, we do these a lot. If people come in and have knee injuries, we're going to kind of test these ligaments where you're going to have the person kind of laying on their back. Their knee's going to be bent, and what you're going to do is try to pull the tibia forward, or you're going to try to push the tibia posteriorly, and you're trying to see if there's any sort of excess motion that's not supposed to be there. Okay, so anterior cruciate is going to, the reason it gets its name, it's going to attach to the anterior part of the tibia. So it's going from the femur down to the tibia. It's going to attach on the anterior part of the tibia, and this is its job. It's going to prevent forward sliding of the tibia on the femur. So it's preventing you from pulling the tibia anteriorly on the femur. And again, that's exactly how you sort of do the test or the orthopedic test. Posterior cruciate is going to insert on the posterior tibia. And for this one, it's going to prevent backward sliding of the tibia on the femur. So the way I've kind of listed them is, what is the tibia doing? But you can do it kind of in the opposite ways too. But it's easier for me just because we had to do these orthopedic tests where we're trying to pull the tibia forward or we're trying to push it posteriorly. It always just made more sense to me to sort of think about it in, what is the tibia doing and what movements are these cruciate ligaments doing or in which ways are they preventing the tibia from moving. Okay, so anterior cruciate prevents forward sliding of the tibia on the femur. Posterior cruciate prevents backward sliding or that posterior movement of that tibia in relation to the femur. Okay, so here is a great picture, and again, this is a great one for your practical because it kind of has everything that I would kind of ask you to kind of label, right? So it's got my femur, it's got my tibia, I have my fibula. So because my fibula is over here, I know that this is the lateral collateral or the fibular collateral. That makes, I know my tibia is medial, so I know this is going to be the medial collateral ligament. And then I get my cruciate. So anterior part of the tibia, anterior cruciate, posterior cruciate back here, and it's going to insert on that posterior part of the tibia. I also get to see where my femur is covered in my cartilage, and I also can see, this is kind of the first look we've had at my meniscus here, and again, this is just going to be an extra layer of fibrocartilage that's going to help this femur kind of sit in these little pockets on top of the tibia and just add a little bit more cushioning, a little bit more stability. But these are the ones when people talk about I have these meniscus tears. It's this tearing of this fibrocartilage, okay? And sometimes it'll tear and kind of fold back into the joint space. And one of the things that you'll find a lot when you hear people talk about knee pain, or that we'll ask a lot is, do you have any locking? Does your knee ever feel like it locks up? And one of the main things that happens when people's knees start to lock up is a lot of times it's going to indicate that there's some sort of meniscal tear, okay? So really, really important picture to be able to find all those structures that we talked about. And this, again, is one that's going to show up on your practical where, this will probably show up a bunch of times where you have to label all the ligaments and all the bones and all the different parts in the meniscuses, okay? But I know this is the lateral meniscus because, again, the tibia kind of shows me that, right? Tibia, lateral side, lateral collateral, and that makes this the lateral meniscus. Tibia, medial side, that makes this the medial meniscus, and it helps me to know that this is my medial collateral. Okay, and then I get the tibia here. I know this is my tibial tuberosity. I can see the patella. I know that this is the anterior side. So this insertion of this ligament on the anterior tibia makes it the anterior cruciate, and I can see that this one is a little bit more behind, so it's going to be that posterior cruciate. Okay, but very important just again to orientate yourself on all these images and to kind of practice these with your labeling so that when it pops up on your test, you're ready to go. Okay, but very, very, very important one. Okay, so here is another one. If we took your femur kind of right off and we were just looking down at the top of your tibia, okay, so I can see this little tibial tuberosity and that little bump on the front part of your tibia. That kind of helps me know that this is anterior, right? This is going to help me know that this is the anterior cruciate. That's going to help me know that this is the posterior cruciate. Okay, now with this one, it's a little tricky because I don't see the fibula, so it's a little harder for me to sort of figure out which one is the medial side versus which one is the lateral side. But this is the little trick to doing this, okay? So if you look at these meniscuses, and they talk about them where they're going to be kind of C-shaped, okay? And this one's kind of like a backward C. But the way you tell which one is medial versus which one is lateral is that most of the weight that we put on the tibia is going to be on the medial side, and that's where when you look at arthritis, you're going to recognize that, okay, arthritis usually is going to occur on that medial side because that's the side that we kind of load up, and because of that, that medial side is going to be a little bit bigger, okay? So you can tell this one's a little bit bigger. And then the other way you can tell is that they talk about an open C versus a closed C. So you can see that the ends of this meniscus, so if this is one end, and this is the other one, they're pretty far apart, and they call that an open C, okay? And with this one, the two ends are pretty close together, and they call that a closed C. So the open C is always going to be on that medial side. So that's just another trick that you can use to sort of know, okay, let me make sure I get these meniscuses right. It's bigger on the medial side, and I'm going to have the open C on the medial side. And again, I'm getting the cruciates because I'm going to find that tibial tuberosity, and then I can get my anterior cruciate and my posterior cruciate. Okay, so knee joint heavily reinforced by our muscles, and again, we want to always remember that we're gonna, these muscles are gonna provide stability, but only when they're active. And then the thing that I want you to really, really understand is that we're gonna lose a lot of that stability if my muscles are fatigued or if they're injured. And this is where I start to rely on those ligaments, and this is where I start to sort of damage the ligaments and the joints when my muscles can't protect me properly. Okay, so now we get to the shoulder joint or the glenohumeral joint. So this is again my humerus coming up and fitting in this glenoid cavity on my scapula. So this is my ball and socket joint, which tells us that it's going to give me a ton of motion. I get this glenoid labrum, so we'll see it in a picture here, but it's kind of like the meniscus. It's a small rim of fibrocartilage surrounding the glenoid cavity. I get a loose and thin articular capsule. I get a few ligaments to reinforce the shoulder. So I get this coracohumeral ligament, and these are nice because the ligament the name kind of tells you where it starts and finishes, right? So this one's going to be the coracoid going to the humerus. So this is going to be superior. And then I'm going to get these three glenohumeral ligaments, and they're going to be anterior. But again, because I have so much motion in my shoulder, I can't surround it with these really big, huge, strong ligaments. So they're just going to be pretty weak, okay? They're not going to provide a lot of stability. They're not going to provide a lot of protection. I'm going to have to get most of my stability from those muscles and those tendons. And then we'll come back to that a little bit when we get into the muscle chapter and we start talking about our rotator cuff muscles. Okay, but here is my shoulder, and I want to find all the things, right? Acromion, I want to find the coracoid, I want to find the humerus, and then I just want to realize that, I have some ligaments, but they're not giving me a ton of protection. But what they do is the name kind of tells me where they go from, right? So here's my coracoid, coracohumeral, going from the coracoid to the humerus, and then I have my glenohumeral, and they're going to go from that glenoid cavity, and they're going to run over to the humerus too. And the hip ones will be very similar, where the names will kind of tell you. So you don't necessarily have to memorize them. You just have to remember, okay, if I just know the landmarks that they're starting and finishing on, I can get the name correct. And here is a picture if, again, we took the humerus out and we were just looking into the socket of your shoulder. I get a good look at this glenoid labrum. That kind of makes that pocket a little bit deeper, but again, it's still really, really shallow. And again, I like this picture a lot because it shows me that the coracoid is a little more anterior, shows me that the acromion is going to be a little more posterior. And again, when we put that humerus in here, the maintaining of that little gap between the head of the humerus and this acromion is really, really important to all your shoulder impingements and all your shoulder injuries. Okay, so those rotator cuff muscles have to be strong because they're going to keep that bone in the socket, and they're going to keep us from impinging all those structures that are in between those two bones. So now we get to the elbow joint. This one's pretty simple because our elbow just moves in really one direction. So it's a hinge joint, allows flexion and extension only. We get this articular capsule. It's going to be thin anteriorly and posterior. We have only two really ligaments that we want to be worried about, but they're very strong, okay, and they're preventing this side-to-side motion. We get an ulnar collateral, which again, we want to remember that the ulna is medial, so it's going to be on the medial side. And we want to remember that the radius follows the thumb, and in anatomical position, it's going to be on the lateral side, okay? And then we get additional, again, supports from the muscles, but a lot of the elbow is kind of the way the bones are structured, and we have all those little fossas. Our elbow is really, really, really stable. And then we just have to remember that the radius, when I supinate and I pronate, it's just going to spin proximally, sort of in that little groove that it sits on the ulna. So here is my elbow joint. So humerus, ulna, radius, okay? And I get these little radial collateral ligaments. Okay, and on this one I get this ulnar collateral ligament, and then I also get this annular ligament that goes with that head of the radius, and again the radius is just going to spin in that little groove and allow me to sort of supinate and pronate my forearm. Okay, so not too much to know about the elbow, so that one's pretty simple. When we get to the hip joint, again, it's going to be very similar to your shoulder, just a little more stable, right? A little more deeper socket. So it's a ball and socket joint. The movement is limited. So this is the difference between those questions about the difference between the shoulder and the hip are really good questions for your multiple choice too. Okay, so movement is limited by strong ligaments and a deeper socket, and we also get these big, huge muscles that surround the joint too. Okay, the head of the femur articulates with the acetabulum, so it's fitting in the acetabulum of the pelvis. The depth of the acetabulum is enhanced by another labrum. Okay, so there's my fibrocartilage again to kind of fit that bone in there properly. And then my hip joints are rarely dislocated based on all these things above, right? Deep socket, strong ligaments, big muscles. We also get this thick articular capsule that's going to completely enclose the joint. Okay, and then here are my hip ligaments. And again, if you know the bones and you know how to label the bones, the ligaments are going to be easy because it's really just where do they start and where do they finish. So we get an iliofemoral ligament, so it's going to go from the ilium to the femur anteriorly. We get a pubofemoral going from the pubic bone to the femur again inferiorly, and then we get an ischiofemoral going from the ischium over to the femur, and this one's going to be a little bit more posterior. So if I can label that pelvis, these ligaments will be really, really easy. So again, don't feel like you have to memorize them. You just want to remember, okay, when I look at the photo, I just need to go, where do they start, where do they finish? So they're arranged to rotate the head of the femur into the socket when you're standing. That's going to give me a little bit more stability. We also have a ligament on the head of the femur, very similar to the shoulder. This one's going to contain an artery, and again, it's just going to provide some additional support for me. And then again, I also get a lot of my support for those hip muscles, or for that hip joint, from my muscles and from my glute muscles and everything kind of surrounding it. Okay? So here's a picture of, and again, it looks very different from the shoulder, and you can see sort of how deep that socket is, and how much that head kind of fits in there, and how much it's kind of locked in compared to where your shoulder, the head of the humerus is really just sitting in this shallow little bowl. Okay, so much more stable, and again, just comes from that the forces produced when we're moving around, and just this need to sort of bear the weight of the whole body and absorb those forces. Here is a picture of our ligaments, okay? So this is posterior, and I know that because I can see the ischium, and we know that that's on the back part of the pelvis. But this is my iliofemoral, so ilium to the femur, okay? And then this is my ischiofemoral, ischium over to the femur. And if I can see that ischiofemoral, I know, again, I'm looking at the backside, okay? And then if I come to the anterior part, and again, I can see that pubic bone here, but I can still see the top part of the iliofemoral, okay? But I also get this pubofemoral that's going to run from my pubic bone all the way over to, again, my femur. Okay, so again, that anterior, posterior, medial, lateral, orientating yourself, really, really, really important to sort of be able to label these properly. Okay, but again, try not to memorize stuff. Try to kind of think it through, and then that way, if something comes up that you don't remember or you're just not as familiar with, you can figure it out. Now we get to the last joint we're going to look at, which is this temporomandibular joint, or your jaw. A lot of forces creating in the jaw. There's a lot of things where you kind of tell people, like, if you're having jaw pain, you really want to get it taken care of really, really quickly, because those jaw motions, the forces produced are really, really high. And sometimes as they kind of linger, they get just a little bit harder to kind of get rid of and sort of get things back to normal. So jaw pain is, again, a really, really important thing. It's a modified hinge joint. You get the condylar of the mandible is going to articulate with the temporal bone. So this is a good multiple choice question too, is that mandible is actually going to sit in this little groove on your temporal bone, and we'll see it in the picture here too. We get an articular disc that protects the joint surfaces, so you just have this tiny little disc in there, which is why when it gets damaged, those two bones again start rubbing together, and then we get a lot of pain and discomfort because, again, those bones are really, really sensitive. We also get these lateral ligaments that enclose the joint, and you get two types of movements. We get that opening and closing, but I can also kind of glide my jaw forward, and I can kind of glide it back a little bit. So here is a picture of that mandible, and you can see this is my temporal bone because I see that external acoustic meatus. These are my lateral ligaments here and the capsule. And then if I take those away, I can see the condylar process of the mandible and how it comes and just sits up in this little groove, okay? And then you're going to get the disc kind of in between those. But again, the disc, it's really easy for that to get damaged or wear away. and then again I start to have a lot of pain. You have a lot of people, the first thing you want to do is kind of get people to stop chewing gum, stop grinding their teeth at nighttime. There's a lot of things that we do throughout the day where we just kind of load these joints all the time, and then again it just creates a lot of kind of wear and tear. The other thing you'll find with people with TMJ pain is if you just go home and you're sort of looking in the mirror and you just open your mouth slowly, you'll see that your jaw kind of, sometimes when it opens, it doesn't open straight up and down. It'll kind of deviate to one side. And a lot of that is just based on these muscular imbalances that we create. Because if you think about it, most people are going to chew their whole life, they're going to chew on the same side. And what happens is that we just, especially if you chew gum, you're going to really, really build those muscles up on the one side, and the other side's going to be a little bit weaker. And then we're going to create these imbalances in movement. And then again, it's going to create this sort of increased or this advanced deterioration of the joints on the one side versus the other. Okay, so one of the very, very first things you're going to do for somebody if they have a lot of jaw pain is kind of take out any sort of the gum chewing and try to see if they're grinding their teeth or they're clenching their jaws sort of at night or throughout the day. Okay, so that's it for Chapter 8. Now we're going to go back and sort of look at Chapter 6, and we'll look at all the bone physiology, and then we'll be ready for our Unit 2 test.